World Diabetes Day is this coming Thursday. So we do. It seems like now we're doing this annual talk, so that's fantastic. Hopefully, we're getting incredible turnout, and maybe we'll do it more than once a year. But yes, for those of you who are not aware, insulin was discovered in Canada. So one of the doctors that discovered it was from Canada, and his birthday was on November 14th. And so, therefore, November 14th has been World Diabetes Day, just to remember him for the great contribution he gave to this world. And yeah, just remember that's where it was discovered here in Canada. So, in regards to today's talk, I'm gonna do a wide spectrum in regards to covering blood sugars in general, pre-diabetes, diabetes, and linking to cardiovascular disease slash risk. So this will be very important for those of you who already have cardiovascular disease and perhaps have pre-diabetes or diabetes. And of course, I'm also going to go over ways to manage your blood sugars. Again, it's not going to be very detailed, right? Because of the amount of time that we have, but I'll definitely go with as much as I can. All right, so we're going to go over diabetes statistics and trends, which is the next slide. Really define what prediabetes is as well, what the difference between prediabetes and diabetes is. And I'm not talking about the actual numbers or the readings that can get you diagnosed, but what's actually happening inside your body. What's the difference between prediabetes and diabetes? Okay, and the impact of high and low blood sugars when it comes to your heart, your blood vessels. I'm not going to cover chronic high blood sugars or chronic hyperglycemia when it comes to other um, complications when it comes to diabetes. Okay, we just don't have the time, but I'm focusing more when it comes to your heart health and your blood vessels. All right. All right. So this is gives us a little bit of a snippet, a little slide when it comes to diabetes as a whole in the entire world. I don't want to spend too much time on this slide per se. The biggest number I want you to see is just in Canada. On average, about 10% of the adult population, so that's from the age of 18 to 80, has diabetes, and about 30%, 27% or so have pre-diabetes. Okay, just a little reminder, just because you have pre-diabetes doesn't mean you're gonna get diabetes. Okay, so that's something very important. I know some folks think that just because you have pre-diabetes is already like established that you're gonna eventually get diabetes, and that's not the case. Most people that do have pre-diabetes will not get full diabetes. That's not to say that there's no complications from pre-diabetes, which I'm going to go over as well. As you can see in this slide, it's a worldwide, epidemic. Pakistan has the highest rate at 30%. Okay, and China has 11%. They have about the average when it comes to the percentage relative wise, but they have the most people with diabetes because 11% of 1.1 billion or whatever it is they are at is a lot more than most countries, right? And Canada falls around 8 to 10%. Okay, so here are the definitions when it comes to pre-diabetes. So anyone familiar with your blood work, and you should be, anyone that is in this program should always be getting their blood work done. And one of the things that we do measure here in cardiac rehab is blood sugars uh, and also your 3-month average when it comes to blood sugars. Just because it is um, such a marker when it comes to establishing your risk, when it comes to future cardiac risk. We want to make sure that these are on target. So as you can see here, at the very top of the table there, we have a fasting blood sugar of 6.1 to 6.9. And then we have at the very bottom that HbA1c. HB stands for hemoglobin. So it's the amount of sugar attached to your red blood cells. So if there's a lot of if there's a lot of sugars in the bloodstream, they will attach themselves to your red blood cells. And they typically last about 3 months. Every 3 months, your red blood cells turn over, so your body's making more. That's why we call it a 3-month blood sugar average, because after that time, your red blood cells turn over, you get more, right? So you're looking at a number between 6 and 6.4% for someone to have pre-diabetes. Anything below that would be considered normal. Okay, and anything above that, you could say that again, it's in the diabetes range. Okay, so one thing I want to ask all of you is, why do you think they selected these numbers? Where do you think these numbers come from? Like, I know that we see these numbers here in front of us, but what is happening inside your body, inside your blood vessels, for example, that made them, the people that do all that research, say that pre-diabetes is this range and diabetes is above this range? Can anybody take any guesses out there of what is the difference? Why these numbers? No guesses? What happens to people that have diabetes that are now well managed for a very long time? What tends to happen? What are some of the stories you hear?
Feel free to use the chat box to write in anything.
Okay, so the difference is, once you pass those numbers that you see there in pre-diabetes, so specifically when it comes to the 3-month average or the A1C, once you hit 6.5%, they say diagnosed with diabetes, and they can start to predict what's called retinopathy. So retinopathy is that damage that happens in the retina of your eye. For someone who has high blood sugar or hyperglycemia for long periods of time, it can eventually cause damage. So that is the reason of how they selected this range. Once you hit 6.5%, they can predict the beginning of microvascular complications. So microvascular meaning the very small blood vessels in your body. So for example, when it comes to your eye, like I said, retinopathy. When it comes to kidney disease, we know that diabetes is the highest promoter of kidney disease, for example. Okay, so that is the main reason. Okay, how they selected those numbers. So so if someone with pre-diabetes is not at risk for those complications that we often hear about, like for example, I was talking about the eye, kidney disease, for example, or nerve issues, that kind of stuff. You're not at risk for that, but that's not to say that pre-diabetes should just be ignored. Um, Pre-diabetes, when you match it up with other risk factors, and you can see here in this slide, I have here on the right side, it says insulin resistance. So insulin resistance, or you can say pre-diabetes, for example, if you have these other risk factors involved, at least 2 more, then you're what's called the metabolic syndrome. And it's been shown that this combination of risk factors together increases the risk of cardiovascular disease and events, okay, like heart attacks, for example. So someone that has pre-diabetes and has 2 or more of these risk factors that you see here puts you at a risk when it comes to cardiovascular disease and events. So even though you have pre-diabetes and you're not at risk when it comes to the diabetes related complications, you're still at risk when it comes to your heart health. Okay? Everybody okay with that? And if you have 3 risk factors listed here on this screen, but you do not have pre-diabetes, so let's say you have high blood pressure, high triglycerides, and you're overweight or obese, then it puts you at a greater risk of developing pre-diabetes. Okay? Everybody okay with that slide there? Any comments or questions out there? Okay. So on average, okay, why is diabetes so important? Why is pre-diabetes so important when it comes to cardiovascular disease? On average, someone that has diabetes will have a cardiac event. So that means an event, it means a heart attack, for example, or procedure, a stent, bypass, 10 years earlier than someone who does not have diabetes. Okay. And I'm going to go over the reasons why. That's not to say that just because you have diabetes, immediately you're gonna have a heart attack 10 years before the average when it comes to someone who does not have diabetes. But it's taking into account all different types of folk, right? It's taking into account people who are not well managed when it comes to their blood sugars, very, very elevated, and those that perhaps are well managed. So if your diabetes is well managed, you're probably going to have a cardiac event or procedure at about the same amount of risk or time as someone who does not have diabetes if you have other risk factors involved. Okay, so I don't want anybody to worry that just because you have diabetes, it automatically sets you off to have some sort of cardiac event 10 years before someone who does not. If your other risk factors are on target and your diabetes is on target, then you're pretty much at the same risk as someone who does not have diabetes. Everybody okay with that? You guys are kind of quiet out there. Okay, you gotta throw me a thumbs down or a thumbs up or there we go. Okay, do something out there because I'm just wondering how you guys are reacting. Please remember that this talk is for you. I mean, I'm going based on the slides, but I don't have to finish the slides. It all has to do where you guys want to take it as well. Okay, we do have a hand up.
All right, I'm just going to go unmute the microphone for Larry. Okay, Larry, I've allowed your microphone, so you're able to unmute your microphone. You have to do that part from your side, and then you can ask Michael your question.
I didn't have a question. I was trying to find out where the thumbs up and thumbs down were, so I was surfing. Sorry. Did you hear that?
Was that your question?
No, I didn't have a question. I was trying to find the thumbs up, the react, and I hit
Okay.
the wrong
All
button.
right. Okay. All
But
right,
while I
Larry.
have
So we're
you,
gonna move.
while I have
We're
you,
gonna
will we
move
get
forward
copies
then,
of the
okay?
slides?
Okay. Let's move forward then. Okay. So
thank
thank you,
you,
Larry.
Larry.
Sorry.
All right. I
I
think
think
somebody has their.
their.
Okay. So I mean, this is just to give you a little bit extra from the previous slide in regards to someone with diabetes when it comes to cardiovascular disease. So like I said, on average, 10 years before, sometimes 10 to 15, and you're a great risk of developing, again, like I said, heart attack, angina, even after having your heart attack and having your surgery, your procedure, having more complications. That's why when somebody comes in for any sort of procedure, they get your blood work done. They're measuring other things, but they're also measuring your blood sugars. So if your blood sugar is elevated, even if you don't have diabetes, because it can happen because your body's going through a lot of stress when you're having a heart attack. So they're gonna bring those sugars down with insulin if they need to, even if you don't have diabetes. And that's another reason why when you come to the hospital, they check your blood sugars and they also check your 3-month average when it comes to your blood sugars. Because someone having a heart attack, your sugars could be very elevated because of the stress going on. So you could be elevated, but your 3-month average for your blood sugars could be normal. So then they could say, oh, you know what? This person came in, the hyperglycemia or high blood sugar is stress related, but this person does not have diabetes because their 3-month average is normal. So that's something that they will always do as well. So this is pretty much what happens. This is your blood vessels. Okay. We have something called vascular aging. It's kind of similar to, how when someone says that person looks young for their age or that person looks older for their age, you have like biological aging, chronological aging. It's the same thing with your blood vessels. You can have your blood vessels older or younger than your actual age. So we call this vascular aging. So someone who's very fit, perhaps, has no family history when it comes to risk factors in cardiovascular disease, their vascular age would probably be younger than someone their typical age. Now, if you take into account someone that has diabetes, for example, their vascular age tends to be about 10 to 15 years older than their actual age. And the reason for that is because with diabetes, specifically when it comes to chronic hyperglycemia, high blood sugars, you're going to have an increase in inflammation when it comes to your blood vessels. And we know that inflammation is one of those risk factors that damage the interior artery of your blood vessels, which then promotes plaque buildup. And also diabetes tends to decrease the likelihood of your body breaking down blood clots from forming. So somebody who has diabetes is more likely to form blood clots. So you have someone with diabetes, higher vascular or blood vessel inflammation, which leads to damage and therefore plaque buildup in the blood vessels, and also higher risk of blood clotting. And that's why, for example, many, many years ago, when I first started working here, drug-eluting stent was fairly new. Now you see that for everybody. But a drug-eluting stent, when you are given a stent, they're all made of metal, but the drug-eluting stent also has a coating, like a drug coating, that is trying to prevent clotting from occurring. So this was first given priority to when it comes to individuals who have diabetes, because they are a higher risk of blood clotting. But now pretty much everybody gets it, right? But just giving you the heads up of this is why people with diabetes, when their blood sugars are not well managed, this is why they tend to get heart attacks or other events or procedures at a younger age than someone who does not. Inflammation in the blood vessels and increase of blood clotting. Okay. So we know there's a risk when it comes to elevated blood sugars, hyperglycemia. The next thing I'm going to talk about, I'm not going to talk about it too much because I don't know how many people here actually have diabetes. And more than typically, when we're talking about hypoglycemia or abnormally low blood sugar, it's typically for people who are on insulin, pretty much. Okay. But any guideline that you tend to define what hypoglycemia is, it's pretty much a reading of blood sugar of under 4 if you're taking insulin. Okay. The person may have symptoms or no symptoms, and they actually respond well to carbohydrates. So, for example, sugar eats or Dex4 tablets, for example. Okay. So, someone who, for example, if I have a patient here in cardiac rehab and they have cardiovascular disease, right? They had a heart attack or they had stents or they had a bypass and they have diabetes and they are on insulin, for example, if they go low, right, that puts a great stress on the heart because anytime somebody goes low like that, and we're talking low like very rapidly, the insulin is too much for their body. Maybe they missed a meal, or maybe they added too much insulin, or maybe they didn't eat enough. But regardless, this person's blood sugars is plummeting, and that tends to increase the heart rate because the body's trying to release some stored sugar from their liver, which is where your blood sugar, most of it is stored. So if someone is going low, your body's going to try and fight back. So the heart rate has to go up because that heart rate, that adrenaline, is a signal to the liver to release more sugar. So anytime you have a high elevation in heart rate, it puts you at a greater risk of cardiovascular events, heart attack, irregular rhythms, etc. So that's why someone with diabetes who is on insulin, for example, you want to avoid going low. Number one, because if they go too low, then they could collapse, but also to protect their heart as well. Okay. So a rule of thumb is, and I don't want to spend too much time on these slides over here. Rule of thumb is, if you have diabetes and are on insulin, your doctor's going to do everything possible to avoid going low. They'd rather you are a bit high than going low because that's much riskier. Okay. And again, like I said, if you go low quickly, greater heart rate, greater risk of irregular rhythms, greater risk of heart attack, and also even greater risk of inflammation, as I said, when you also get it with high blood sugars as well. Yeah, so I don't want to spend too much time in that one, because I'm if you are in that situation, you should definitely be following up with your diabetes care provider, right, and not ignoring that. Okay, so back to the numbers. Okay, so we talked about pre-diabetes, right? What kind of the number range? What we're talking about. If you are someone that is monitoring their blood sugars through blood work, so for example, you don't have pre-diabetes, you don't have diabetes, but your doctor's always sending you, because as the older we get, obviously the greater risk you have to developing that, right? So as you can see here, for those who are living without diabetes, general guidelines are, if you're going to get your blood work done, your fasting should be between 4 and 5.9. 2 hours after a meal, it should be under 7.8. And your 3-month average should be between 4 and 5.9%. So that would be your typical normal numbers, okay? If you are living with diabetes, for example, your fasting, ideally, again, it's not always going to be perfect, because remember what I said, if you're on insulin and you are at a risk of going low, your doctor would prefer you are a bit elevated rather than going low, because that's riskier for your health. But rule of thumb, for the most part, fasting between 4 and 7, 2 hours after a meal between 5 and 10, even better between 5 and 8 would be a tighter range for you. And then your 3-month average should be less than 7%. Now, if you can recall back to that previous slide I showed you when it comes to your range of numbers, remember I mentioned the number 6.5%? That at that time they can start possibly monitoring for retinopathy when it comes to the damage in the eye. Why is it not under 6.5%, but instead under 7% when it comes to someone with diabetes? Can anybody throw any guesses out there?
You do have a hand up, Michael.
Okay, go ahead.
Okay, I'm just gonna unmute the microphone or okay. All right, your mic is allowed. If you want to unmute, you can ask Michael your question or answer his question.
Okay, my question is,
Unmute your microphone. You have your hand up there.
Go ahead, sir.
the question is there a relation between the moles mmol per liter and the HbA1c percentage?
Yes. So pretty good question. Yeah. So pretty much when we're looking at the so if we go back to the bottom numbers there, between 4 and 7, that correlates to the 7%. It's pretty much the same thing. Yes, it is. Thank you for clarifying that. Whenever you get blood work done, or if you do check your blood sugars, right, that millimole per liter is going to be the sugar value at that exact moment in time.
So
right?
that will be equivalent to the percentage.
No, so it will correlate, kind of, because you got to remember that the percentage is a 3-month average.
Oh.
And then the millimole per liter is that exact moment in time. Like right now, if I were to check my blood sugars right now, it would be for 7:25 p.m. only, right? And then the percentage is for 3 months. So you always got to keep that into consideration. That's why, for example, if someone is checking their blood sugars at home with a glucometer, for example, they're measuring for that exact moment in time. And that's how they're able to make changes in their lifestyle. So for example, maybe they had their dinner and they check 2 hours after dinner and they have a blood sugar reading of 12. And they have a blood sugar reading of 12, for example. That's a bit over the target. So that's that sugar number at that moment in time. So therefore, they're able to look back at the guidelines. They're looking for between 5 and 10, and they can then think about, okay, you know what? that was a bit elevated. What was in that dinner that I can change, right? So remember that millimoles per liter is for that moment in time. The percentage is for 3 months, okay? So keep that into account. And I'm just going to answer the question right now that I asked myself. So the reason why it's under 7% and not under 6.5% is because once you hit over 7%, that risk for retinopathy or microvascular complications to the small blood vessels significantly increases. So there's a bit of a much higher increase. So that's why for people with diabetes, it's under 7%. And when it comes to time of diagnosis, so when somebody diagnoses you with diabetes, it's 6.5, right? 6.5, they can start measuring the possibility of damage when it comes to the small blood vessels. Once you get over 7%, the risk of those small blood vessels getting damaged is a much higher risk. And that's why the value of 7% has been selected. Okay, so that's why there's a bit of a difference there. Okay. Oh, there we go. So actually, I think we're doing not too bad with time. I'm just going to go over, if anyone here is interested in how do I monitor my blood sugars. When it comes to the Canadian diabetes guidelines, any guidelines when it comes to diabetes in the world, people are always encouraged to check their own blood sugars. You got to remember that when it comes to diabetes, it's a very dynamic type of risk factor, right? And in order to find out truly where you can make some corrections to your meals, or if you are taking insulin to your insulin, for example, you have to check your blood sugars. I know for some of you, maybe your doctor may advise to only get blood work done, but if you only get blood work done, remember, it's only going to show you a 3-month average. It's not going to tell you that, hey, you know what? Every time I go to dinner, that's when my sugars are much higher than, for example, when I'm eating my breakfast, right? So the only way to find out truly from day to day how your sugars are doing is to you yourself check your blood sugars with a glucometer that you can see here at in the middle, or some sort of device that you can wear yourself, where you actually scan, which you can use with your phone if you're downloading app, or if you actually have a little electronic reader that's specific to that device. So typically here we have Libra, but there's also the Dexcom. But regardless, you will always get blood work done, okay? Because that is the most accurate way to measure your blood sugars, right? So that's so what I'm trying to say is you want to use everything at your disposal, right? To give you the highest chance to live with diabetes or pre-diabetes, by making as many changes as possible when it comes to your eating, or other, by knowing what your sugars are day to day, and of course at the same time getting your blood work done. Okay. So like I said, blood work is the most accurate way, and usually your doctor is looking for that 3-month average more than anything. Very quickly here, the 3-month average when it comes to your blood sugars. If you're not on insulin, this is not going to be as impactful, but if you are on insulin, this slide is very important. Remember, the 3-month average is an average, right? It's an average. It's an average of highs, and it's an average of lows. So if you are on insulin and you go low a lot, and perhaps you're also up a lot, your 3-month average may actually be normal. Because as an average, if you're very low and very high, maybe you're somewhere in the middle, in between when it comes to an average. So your A1C or your 3-month average may actually be normal. I've had many patients who are on insulin, for example, who their blood sugars are high, but their A1C or their 3-month average is normal. So that's why you can't really just go by the 3-month average. You have to use everything at your disposal. So if you're on insulin, you have to be checking your blood sugars every single day. Rule of thumb is you want to check at least once per insulin injection. So if you're taking 4 injections, you got to be checking at least 4 times a day. And that's why it's always recommended also, if possible, again, it all depends on your insurance and, coverage and all that. Someone who is taking many insulin injections to wear some sort of like sensor device, because it'll be a lot easier on you, right? But it's just to show you that you can have a normal 3-month average when it comes to your blood sugars and still not really be in range when it comes to your blood sugar management as a whole. Does everybody understand that that slide? I think we have some questions. What is the best time to measure blood sugar, after breakfast or dinner? So this is a great question, Abdul. So you can check as often as you want. Okay, it's all up to you. I have patients who check multiple times a day, even though their blood sugars are fine and they're only taking metformin because they want to do it. That's fine. It's up to, you know what? If you want to do it, Abdul, you can. You can check as often as possible. If you're going to check your blood sugar after a meal, you do it 2 hours after first bite. So let's say you started eating at 8 a.m., 10 a.m. is when you check your blood sugars. And this is a great way to find out how your meals are doing and how your body is handling your meals. Okay. Very important as well. If you eat out, that's another good example. Maybe your dinner, your 2 hour after dinner sugars are fine, but every time you go out to dinner, I don't know, wherever you go, then they're high, right? And that will strike a correlation with you saying to you that, you know what, most of the time that I eat out, my sugars are much higher. But when I eat at home, they're a lot better because you can control what you're eating. Okay. Did I answer that okay for you, Abdul, there? Okay. So you can check. I would say always aim to check the meal that you suspect could be the problem, right? When it comes to finding out what you can do, what you can change in regards to your meal there. Okay. The glucometer. Okay. This is going to be something that everyone that has diabetes should have, whether you have one of those sensor devices or not. Okay. And I'm going to go over why. Okay. The glucometer is always going to be more accurate than those sensors that I showed you before, like the Libra or the Dexcom. The blood work is checking your blood sugar, right? Whenever you go for blood work, you're checking blood sugar. Whenever you're using the glucometer, you're checking blood sugar as well. But when you're using the sensors, you're not really checking blood sugar. And I'm going to go over what that means. And Abdul, you kind of answered my question here. When is it a good time to check your blood sugar? Whenever you suspect a meal, like if you introduce a new meal into your regimen, that could be a good time to check just to see what your body's reacting to. If you're on insulin, you want to be checking as often as you take insulin, but you want to aim to check during different times of the day and see how your body responds to exercise. Remember, exercise is like extra insulin. Okay, so always be mindful of that. So that's why somebody who is on insulin, if you start exercising, just pay attention how your sugars are doing, because if they do start going lower than the norm, you may have to have a conversation with your diabetes care provider and ask, hey, you know what? I started exercising and I noticed my sugars are much lower than they used to be. So your diabetes care provider may say, you know what? Maybe it's time to decrease that insulin. Okay, you don't need as much, or I don't want it to go too low, right? If you're sick, you should always check your blood sugars, right? Because you tend to have higher spikes in blood sugars when you're sick, because again, you have so many different hormones being released. Like for example, adrenaline would be one of the main ones. So we do have people who have diabetes when they're sick. Their sugars can really spike. Okay, and not only that, if the sugars spike, they tend to go to the washroom a lot. That's why, for example, someone who has chronic high blood sugar or hyperglycemia, they tend to be thirsty a lot, because if your sugars are high, your body wants to get rid of that, and you go to the washroom quite a bit, and you can get quite dehydrated. Okay. So here are the monitoring devices that I was talking about. Okay. I have the Libra here just because this is the one I'm most familiar with, but here's the Dexcom as well in the middle, but they pretty much work the same way. It's a little sensor. If you ever notice somebody with a little white little circle in the back of their arms, that's a Libra device. If you've ever seen that, I'm sure you guys have seen that at one point, right? And so you use your phone if you download the Libra app and you scan, okay? Or you use the reader. It's like a little device, like a little reader. It almost looks like a glucometer. You can see it here on the on the left side, and the same thing, you scan. So you're not actually checking blood sugar because there's no blood there, right? You're not, right? You're actually what happens is the sensor you put it in your arm, or if it's a Dexcom, you put it in your stomach here, and there's a little it's almost like a little needle, but you don't feel any pain when you put it on. But it has like a little sensor that goes into your skin, and when you flash it, a little signal goes from inside under your skin where that little device is located, and it sends a signal to your phone or your reader, which is pretty incredible. And so it's picking up the sugar reading around the fluid of your cells. So not the blood, but the fluid. We call that the interstitial fluid. Okay? So that's why I say that the glucometer is more accurate, right? Because you're actually measuring the actual blood sugar. And then the actual devices that we see here, hold on, let me just, oh, okay. The actual devices that you see here is accurate depending on the situation. And I'm going to go over what that means. So is anybody here using these devices? Because if you're not, maybe I shouldn't go over this because I don't want to be talking about things that maybe none of you be interested in, and rather answer some questions. So you know what, we'll go back to that later on then, if anybody has any questions. Another thing that you want to do if you are on insulin, for example, or even if you're not on insulin but on pills, you want to try and avoid having very highs and then and then very frequent lows. Like for example, let's say somebody goes to the Mandarin, right? Okay. You know what's going to happen there, right? So you may have a very high spike and then you're going to crash down. So you want to avoid those as much as possible. One, because you're not going to feel good. You're going to have very low energy. And two, there seems to be some new research coming on that having those very extreme ups and then coming down actually also does impact your heart, but it's not 100% for sure yet. It's like new research happening right now. I just want to show another slide over here, right, of when it comes to measuring with your glucometer. So when you use your glucometer, you check your blood sugar, you're only checking for that moment in time. This is one part where the scanning is superior, is better than the glucometer. Because if you look at these little red dots here, let's say those red dots is when you check your blood sugar with your glucometer. So you can see here, this person, they were perfect in always checking at the right time, but they missed this highs over here. But if you use the scanner, it gives you an 8-hour window. So it's able to catch all of that. So that's where the scanning is superior to the glucometer, because it gives you an 8-hour window, while the glucometer only for that moment in time. But the glucometer is more accurate when you do the checking as well. So that's why you kind of have to play around a little bit and kind of use both from time to time. What is the app? The app, Praveen, is if you're using the Libra device, which is this right here, you can download. You see the number 2 there with the little yellow square? That's what the app would look like. You would download a Libra app. This would only help you if you actually have a Libra device. And then you would have the app on your phone rather than carrying this reader with you, as you can see on the left side. So that's what that is, okay? Okay, so we're gonna finish up right now. So fantastic. I think I did okay with time there. So recommendations. Diabetes education is something that is recommended to everyone that has pre-diabetes or diabetes. Here in this program, we recommend every 2 years, or if your blood sugars are not on target, ideally you should really be going every year, or every time there is a change in your life, like a major change. So, for example, divorce, death in the family, loss of job, something that is going to impact you very strongly, and perhaps put you with emotions of depression or anxiety, which tend to drive the sugars up as well. And you may not be as, let's just say, careful when it comes to your eating habits during those times as well. Okay. Is there a link to not having diabetes based on family history? Yes. So if you have type 2 diabetes in your family, you have 25% chance of getting type 2 diabetes. And that's why it becomes very important for someone to get their blood work done at a much earlier age than usual, so you can capture that. When it comes to type 1 diabetes, it's not family history really. It's about 5% chance you'll get it if it's been in your family. But the type 2 diabetes is the one that's more prone to family history. How does A1C measure a 3-month average when the blood is only taken up? Is only taken at a single. Yeah, excellent question, John. Yeah, yeah. So they're measuring the red blood cells, right? So they're not actually checking the blood sugar. They are measuring the red blood cells, okay, which they are lasting for 3 months at a time, and they are measuring the amount of sugar attached to those red blood cells, because those red blood cells, they pretty much live for 3 months. Okay, so the A1C is a different test than your blood sugar. Your blood sugar measures that exact moment in time. The HbA1c, they're measuring the red blood cells and how much sugar has been attached during those 3 months. Okay, so that's kind of what it looks like. Is a glucometer better for a pre-diabetic person instead of a Libra? It all depends on you, Dale. Listen, I'll be real with you guys. Like, if you have access to a Libra device, again, it usually has to do with coverage, right? Because if you're paying out of pocket, it's quite expensive. But if you have the means to, and you do have pre-diabetes, um, it's been shown that the more times you scan, you'll be able to see what the sugar reading is like, and therefore you'd be more likely to change your eating behavior, right? So you can even use both if you want, right? So it all depends on what your accessibility is when it comes to coverage, okay? But leave your device with pre-diabetics, that's perfectly fine, because that way you can actually see how your meals are being how your body's responding to the meals in real time. Does exercise help lessen chance of getting diabetes? Yes, it's multifactorial. Weight as well. Not so much, but remember, I don't want to think about weight. You want to think about losing fat and gaining muscle. The more fat you lose, the more muscle you gain. You increase what's called the sensitivity to insulin. Okay, so it does reduce the risk, but even so, some people are really predisposed to getting type 2 diabetes. Even if they're in normal weight, they can still get type 2 diabetes for some folks, right? If their family history is strong. But exercise, proper nutrition, and the medications, if needed, is the foundation when it comes to diabetes management. I cannot find this app. Is it? Oh, okay. So Megan's gonna help you there. So just to finish up with the last slide. So all of these devices that I showed, the glucometer, the Libra or the Dexcom, blood work, I'm not really trying to say not one is better than the other. What you want to do is you want to use everything you got at your disposal, so that if you combine everything together, you're more likelihood to capture real moments in time when it comes to your blood sugar, and therefore make a decision in what to change, right? When it comes to your meals or exercise, etc. Know your blood sugar target. So whether you don't have diabetes, pre-diabetes, diabetes, you have to know what your ranges should be. Okay. Just remember too, if you are older and you're on insulin, perhaps your doctor may ask for you to be above target when it comes to your blood sugars. If that is you, it's because your doctor wants you to avoid going low. Okay. Just remember, when it comes to your health, with your health and your heart, going low is more dangerous, more risky than being up. Okay. And of course, your blood sugars and your cardiovascular health are related. So you want to try and keep those sugars in target, and also the other risk factors as well, like your cholesterol, your weight, blood pressure. So if your sugars are not on target, and then you have other risk factors that are not on target, that's when people's vascular age that I mentioned before tends to accelerate and puts her at a greater risk of developing cardiovascular disease. And also, for those of you who do check your blood sugars, if you do get a high, okay, don't feel bad, don't feel guilty, okay? It's just information. Please remember that when it comes to developing complications with diabetes, it's chronic, long-term, um, long-term time of being high that can cause those effects. Having a high here and there is not going to make those changes. It's just chronic, long periods of time of being high. That's the issue. So if you are high, just take it as information and just say, okay, what happened? Was it that meal? What did I eat? I thought it was healthy, but apparently not. What do I have to change? So you can just make some questions to yourself in regards to making some changes, right? So don't take it as a moment of guilt or shame, please. Okay, just take it as information. And just remember, right? You are the most important member of the diabetes care team. It all starts with you. You're the one who checks your blood sugars every day if you are checking it. You are the one preparing the meals. You are the one taking the pills or taking the insulin, for example. So you're the most important person. So when you go see your doctor is going pretty much only based on the blood work, but you're the one who's gonna carry the weight of that information of what's been going on in regards to your blood sugar management for the last few months. And then your doctor is gonna take both together and then make changes if needed. Okay, so please remember that, right? All right, so we're done. Fantastic. Are there any last questions or comments out here? I'm gonna put my email address here. I'm gonna type it up. If you guys have any other questions or comments, so my name is Michael. I put my email address there for you. Whether diabetes can affect kidneys other than heart disease. So yeah, so diabetes is the number one reason why people get kidney failure. Okay, so they go hand in hand. So if, for example, you have diabetes, if you're over the age of 55, even if your blood pressure is normal, even if when you go for a urine test, there's no extra protein being released from your urine, your doctor's gonna put you on ACE inhibitor medication, which is what's Covercell is the main one, because they actually they act in the kidneys. They relax the arteries, supplying blood flow to the kidneys. So someone with diabetes would be prescribed those medications, because diabetes and kidney disease um, are pretty much like that, right? They're pretty much together, right? Anything else, anyone? Okay, so I would say if you really like this talk, I just make yourself loud. Just say, hey, we would like for Michael to cover more topics. So on diabetes, for example, right? Because there's so much. This is very general. Okay, like this is very kind of basic. I just wanted to go over the numbers. I wanted to go over the risk when it comes to diabetes and pre-diabetes when it comes to cardiovascular disease, and some ways to, you know, how to check your blood sugar kind of thing. That's pretty much what this talk was about, right? All right.
Thanks very much to Michael for